real pleasure to introduce Roy Herbst. Roy, of course, needs no introduction to all of you. You can see his title on the screen, Moving from Palliation to Cure, Progress in the Treatment of Non-Small Cell Lung Cancer. But let me just make a couple of comments. So Roy has really witnessed over the course of his 25-year career or so, since completing training, has witnessed a real revolution in lung cancer. And I remember when I was a fellow and nobody was interested in lung cancer, and there seemed to be little hope for progress in lung cancer. And that has really changed so very dramatically. And as Roy has witnessed it, he's also participated in it. And he has been involved in the vast majority of clinical trials that have led to major changes in lung cancer, whether that's related to EGFR associated lung cancer, or for that matter, trials focused on immunotherapy and other treatments. So great pleasure to introduce Roy. He will take us through this talk and is a great inaugural speaker.
Thank you, Eric, and it's great to be back here in person in the auditorium, and happy Friday, everyone. And what I'm going to do in the next 45 to 50 minutes is give you a little bit of a tour of lung cancer. So actually, my journey began here at Yale 44 years ago, and my PChem professors in the front row, Don Engelman, and it's amazing to see you. And and I actually was in his course. Like, he would probably. But it's Yale's just a phenomenal place. So it's just so amazing for me to be here. And I gave a grand rounds about 12 years ago when I first arrived. So a little bit of progress since then, and I'll show you that now. My disclosures. So we're back. This was last week at East Haven. We had our ASCO review and a dinner for some of the faculty. It was just great to see so many people there. The spirits there. We had a great day discussing all of our different divisions, both solid and liquid advances in the field. And it's good to see so many of those being done here at Yale. And then, of course, we had many of our fellows, and actually we're really multidisciplinary. Of course, we have our hospitals team was there. Many of our fellows were there. We had surgeons there. We'd love to have our surgeons there. Radiation oncology. One thing that I want to get across today is the way we're making progress in lung cancer and many diseases is in a multimodality fashion. And the burden of lung cancer is great. I think most of this group is aware of that, but it's the leading cause of cancer death worldwide. More cases probably a skin cancer diagnosed, of course, but for it's more breast cancer in women and prostate cancer in men. But lung cancer is the #1 killer, with over 2 million deaths a year in the world, with over 200,000 deaths in the United States, 200,000 new cases in the U.S., with over 130,000 deaths. So this is the reason there's so much research and pharmaceutical development in this area. 84% of lung cancer is non-small cell lung cancer. A great effort now still with small cell lung cancer. Used to be that was only associated with smokers. It's still mostly with smokers, but now we know that EGFR mutated lung cancer can develop into small cell lung cancer. And Sheng, who's in the second row, sort of leads that effort here, and she'll probably give a grand round. Oh yeah, please. It is a little distracting. Oh, thank you. And we'll hear from Anne hopefully in this series later this year. Well, when I started out, after I left Yale and I spent some time in New York at Cornell and Rockefeller, I went up to Boston, and I was working at Dana-Farber. And I said this last week at to some of the fellows. I got the job in lung cancer because that's all there was. The breast cancer jobs were all filled. The leukemia and lymphoma jobs. I actually liked lung cancer and was very interested in it. I had a wonderful mentor, Emil Fry, also a Yale graduate. But it was pretty dismal. And it's very hard, as oncologists to work in the clinic when you don't have tools to offer. We had tools of chemotherapy, but this is what survival curves looked like about 25 years ago for lung cancer. And you can see there's really at 2 years, there's very little survival. At 3 years, almost nothing. and progression was quite steep. And there was all this excitement about docetaxel, paclitaxel, gemcitabine, carboplatin. These drugs made a difference, and they did improve survival, but to a very small extent, median survivals of 7 to 8 months. So the question was, a paradigm shift was needed. And you're really a product of your mentors. And I was very fortunate at Dana-Farber. Tom Fry, in the later years of his career, I became his mentee, and we met, at least 2 or 3 times a week. And he always said, take your best drugs and use them early. Use them, in the multimodality setting with surgery, with radiation. And we already had seen that in lung cancer back in those days, because chemoradiation, it was a study done by Dr. Dillman back in the late 80s, early 90s, had shown that there was a benefit for chemoradiation in this disease, and it did improve survival. So what causes lung cancer? I could give a whole talk on this and tobacco cessation efforts that we're doing here and with the AACR. And we have a large tobacco grant here at Yale, and that's very important for our community, because New Haven is a community where smoking is higher than in the rest of the United States. But as I said, many of the lung cancers are non-smoking related now, and you can see actionable mutations. And that's the excitement. This is why so many people want to work in this field, because 20 years ago, EGFR mutations were identified. So we actually know driver mutations, and we can target those. But there are now at least 10 other targetable alterations. And we're seeing evidence of benefit. Now, with a broad perspective, I can see it. Of course, to any given patient, it's still not nearly enough. And I'm sure almost everyone here has some experience, either as a physician, as a family member, as a friend with someone who's had lung cancer. And while we can see that in men, survival, death rates are coming down, and in women with a little bit of a lag, smoking in women began later. But still, if you look in men, the incidence is coming down. A lot of that's screening and smoking cessation, but the mortality is coming down even more. And in women, the same, 1.2 and 3.1. So we are making a difference. And these data, the data you get from the American Cancer Society is always 2 or 3, 4 years old. So I think this shows some of the targeted therapies, which I'll talk about in the first half of the talk, and the immunotherapy benefits are still on the horizon. Well, we've built an outstanding program. We've had retreats over the years. This is a retreat about 5, 6 years ago. And I just want to point out 2 things about this picture. One, actually 3 things. One, this is a great group, multidisciplinary, working as a team. There's myself, that's Dan Baffa. This is David Swenson. We held this at the business school, and David came in and inspired us with some of his, go after the problem hard. He gave a very amazing speech. Of course, David passed away in the last few years. But then I also want to point out, that's Roy Decker. We had one of the best radiation oncologists ever, both as a clinician, as a person, with patients, and he passed away recently as well. So we lost a great member of our team. But I just wanted to say we miss you dearly, Roy. And then we've continued to meet. This is a few years later, and you can see it's a team. The only way we're going to make progress is as a team, as a multimodality team. And this is more of a clinical meeting. I'll show you a translational meeting at the end. But you can see, it's a team approach to lung cancer. And you can see there's Dan, Lynn Tanui from pulmonary, Frank Detterbach, Sarah Goldberg, who unfortunately can't be here today, but she sent me a nice note. And this was over at the West Campus. Now, the centers, these disease centers, thought I'd say a few words about that. We talk about it a great deal. That's the goal, centers of excellence, multimodality centers of excellence, taking care of lung cancer throughout Connecticut, throughout the network. We have, I lose count, what is it, Eric, 15 sites around. We are going to have experts at all those sites seeing lung cancer. We might not have every discipline at each center, but we will work as a team to coordinate and really build a big tent, bring the science to the patients. The only way to continue to make progress, and I hope you'll see that at the end of my hour, is by bringing science to the clinic. That's the theme of today's talk. And we also have a SPORE. So we began the SPORE now, God, it's hard to believe, almost 10 years ago. We have 3 projects in the SPORE. Cyclic 15, which is, and I'll tell you a lot about that. That's actually featured in the CCSG grant, both in the DT and the immunology programs. And it's a new agent developed here at Yale and Liping Shen's lab. Mechanism-based approaches to targeting EGFR, very relevant to the first part of my talk, and brain metastases, which I'll talk about as well. And you can see we have cores, and David's in the front row. We have wonderful biostatistical core. We have developmental programs. And we were first funded in 2015, so this effort began on March 1st, 2011 when I arrived here. We had a number of submissions just for anyone who is getting depressed. It took 3 submissions to get this spore. So it's not easy, but it's been great, and you're going to see why in a moment. And it was renewed in 2020 a lot more easily. And now we're going to renew it again because I've taken on a new MPI and Dr. Paletti, who's in the front row, second row, and working with Li Ping, who remains a co-PI. We're going back in January. So we wanted to wait till the core grant went in, so we weren't competing for the same resources, although there is, I guess, a site visit coming up too. And the beautiful thing about the spore is we have developmental projects, over 50 of them over the years. And you can see these are a career enhancement program, young investigators who aren't working in lung cancer. We're getting them involved in lung cancer. And this is a developmental research program. We could have 10 projects on the spore. The problem is you can really only have 3 projects on these grants because the NCI continues to cut the funds. We have developmental funds and donor funds we use to enhance it. But look at this, all the different departments that are involved. It's building a community of lung cancer here at Yale. And I think there are about 17 R01s. And this is the team. And again, I just want to point out Anna Steppe here, who now Ed Kaftan, actually Julie Boyer many years ago was our initial administrative leader, and then Ed Kaftan for many years. Now, of course, he's working closely on the CCSG, but there's Anna Steppe, Arnal Steppe, who just is doing a phenomenal job and actually made the slide for me. We probably need a second slide. These are all the people that are working in the community of lung cancer research. And then I just want to give a little shout out to Katie. So we went to New York last week, and maybe 2 weeks ago now, and Katie was honored by the Lung Cancer Research Foundation. And see the multimodality team, there's Chen Liu, the chair of pathology, Valentina from genetics, some of us. Really, we're a community that's tackling this disease. So now let's do a little science. I've already used 10 minutes up, but I'm always taking pictures. You see why. So what about targeted therapy? I'm going to tell you about targeted therapy, immunotherapy, and the future. And I might skip through some slides if it's going long, so we have time for questions, because you're here in person, we should be interactive. Well, I began when I finished my my work at Dana-Farber. I went to MD Anderson, and I was telling one of the fellows yesterday when I was meeting with her, it's all about the mentors you have. And I had worked, I'd been at Yale, I had worked in Jim Darnell's lab at Rockefeller. I was very interested in signal transduction, and I was very interested in EGFR and EGFR receptor. And just around that time, the first small molecules and antibodies had been developed against EGFR. And we knew that in epithelial tumors such as lung cancer, EGFR was upregulated. So I was very fortunate. Juan Ki Han, who is my mentor and who had recruited me to MD Anderson, brought me upstairs to the president's office, John Mendelsohn, who had worked in the EGFR field. And these new molecules were coming through, and they offered me the project. And I just said, sure. And I don't think I realized how good it was at that time. I knew that it was a good science, and the science was evolving. And then we started to do clinical trials, but also we worked in the lab to try to identify biomarkers. And I went to start my first clinical trial, and a drug called ZD1839. And the investigator meeting was in Palm Beach, Florida, which is nice. My parents live there. And then I go to the hotel, and who's sitting across from me but Pat LaRusso? That's when I met Pat in 1997. And we started, and we were the co-leaders of this first trial of ZD1839, which became known as gefitinib, and some might know it as Iressa. And we started using this drug, an oral agent, against patients with lung cancer, with what we would call bronchoalveolar lung cancer. And in 1 of 10 patients, we saw this clearing. Unheard of. You saw the survival curves I showed you. And these would be patients who could hardly walk into the clinic, and then a week or 2 later, they'd be feeling great. We didn't know at that time what the biomarkers were. We thought it was EGFR expression. It wasn't. Of course, mutations were found after about 1,000, 2,000 patients were treated, and people looked back. I'll show you that in a moment. We knew that it was women were more likely to respond than men, but it was really people who had smoked less. And smoking, if you smoke, you're more likely to have other mutations like KRAS, and the never smokers did well. We did a lot of skin biopsies. That's when I first met Pat, because we were talking at the meeting about doing skin biopsies, and I was at MD Anderson at the time, and I said, oh, I need to bring in my dermatologist, and we need to do a contract. And Pat just gets up and says, I do them myself, and then sew them up. And I was a little scared of her at the time. It was she was pretty intimidating, and now you know why she's been so successful. She does it herself. Well, then, of course, skipping a little ahead, because it's only an hour talk, about 5 years later, and John Mendelsohn and I used to always talk about that. How can we keep it? Actually, it was 8 years later, the mutations were discovered. How can we do this more quickly? That's why with all the work we're doing with pathology and biomarkers, we've got to be even quicker now. But back then, it took a while. Sequencing techniques were still developing. it wasn't long before this, we were just doing the Maxim Gilbert sequencing and reading the gels, right? So, but a couple of centers, Boston and New York, took the samples from patients who were getting these drugs. These drugs went to what we call an extended access trial. People could get it off label while we were waiting for the drugs to be approved. And many patients were treated. And of course, it was found that in the EGFR receptor, which of course would be a dimer, this is a simplification, in the tyrosine kinase domain, there were specific mutations, mostly at that time discovered in exons 19 and 21. Now we see them in exon 20 as well. And these mutations, of course, activated and caused this to be a driver. And then these small molecules bound into the ATP binding site and were very, very potent. They had some rash, they had some diarrhea, but they were very potent. And that led to, this is actually, being in a place like MD Anderson, patients just flowed in, and we had a big phase 1 clinic. I think we must have treated a couple hundred patients in the first 2 or 3 years, and I led the trial. And that's Cicely Harris. She was one of the first patients, and she was written up in the Wall Street Journal because the idea was we didn't cure her lung cancer. She only lived for 9 years, but we prolonged her survival with good quality of life. And that's why Tara Parker Pope, wrote this article about her. It's like insulin for diabetes or hypertensive medicine. But that's the problem, and it continues to be the problem with EGFR mutated lung cancer. I've been doing this for 25 plus years. No one's unfortunately in the advanced stage ever cured. That's why the work that Katie and her lab are doing, Mark Lemon, I'll show you the project. We have to find new agents because we have to always stay one step ahead of the cancer. And this just shows that. These are the first generation drugs, gefitinib and erlotinib. This was known as OSI 774. For those interested, this was actually a Pfizer drug. And Pfizer, when they took over the Pharmacia drug, they went with the Pharmacia product and made a bit of a mistake because this drug actually became the #1 EGFR inhibitor. These are reversible inhibitors. They're non-specific for mutated cells. They get both wild type and mutated cells. Then there was a second generation drug, afatinib, which also blocked HER2 and HER4. You add more TKI activity, you get more toxicity. We actually did a big trial of this with cetuximab. Showed some increased activity, but not enough. And then, of course, the third generation drug, osimertinib, which was an irreversible inhibitor, which has good brain penetration, and it's EGFR mutation specific. So there's less rash and diarrhea. It can be given to patients for longer periods of time without toxicity. And that's how we were able to move this drug to the earlier stage. And this is just an example. And again, I'm just giving you a bit of an overview today, but the most common mutation for resistance is known as T790M. And in patients that have that, this drug osimertinib, was first studied to target that resistance mutation, which is about 50% of the resistance. And you can see the activity that was seen there, over 60, 70% response. And this quickly became the frontline agent. Again, bring your best drugs to the front line. But again, few, if any, are cured. That's the problem. That's what I'm going to talk to you about now. I was at MD Anderson, and here we put about 110, 120 patients on lung trials in a good year. There we're putting over 300 or 400 patients on trial. But what I noticed, I was leading the lung group there, is we're doing it on 20 different trials. So we said, can we do one trial and use biomarkers to decide who should get which drug? And wasn't easy because, if you have a group that's 20 people, everyone has their own favorite drug. It really is a sociology project. And we didn't have a sociology department there like we have here, or psychology. But what we did is we actually convinced the team that it would be better for all of us to work together on one trial. And we used a little bit of push, and there was a pull, though, because the science was exciting. And at that time, and David Madoff, who's here now, I worked with him at that time, we could get biopsies, core biopsies. Prior to 2004, 2005, most lung cancer biopsies were fine needle aspirations. You had a little bit of few cells, maybe you made a cell block, but you didn't have really enough tissue for sequencing. But now that sequencing was coming to bear, we said, could we do a trial called BATTLE? And we worked with a pathologist, Ignacio Estuba, Jack Lee, a biostatistician, Ed Kim, now at City of Hope, and with our mentor, Wan Ki Hang, we developed a trial we called BATTLE. And what we called it is Biomarker Integrated Approach of Targeted Therapy for Lung Cancer Elimination. So what we did is we had 4 or 5 different drugs. We did a biopsy. We got the result within 14 days. And then we used that result to say, this patient has an EGFR mutation. They should go on erlotinib. This patient has a VEGF upregulation. They should go on vandetanib. And I actually think and we used an adaptive statistical design. And I've talked about that here before. The results did pan out. We found new biomarkers for VEGF inhibitors. The EGFR mutation came out of the story. Now, of course, you say we knew that already, but we didn't. This was before the mutation was fully validated. And we showed that core biopsies were feasible and safe. And this is about when I came to Yale. So when I came to Yale, I said, let's do a battle trial here. And David Rim, my friend in the front row, and that's Jeff Sklar. I miss good old Jeff. You know, he used to always be in the front row at the grand rounds. He'd be here. And I said, can we do a core biopsies? And they told me we had one table where we could do it. You know, there's no capacity. Oh, I was saying I should go back home. And then that was Rocco, who was working with us from the CTO. That's Julie Boyer. That's Emily, who now works as an APRN. She was a research nurse at the time. We put a little team together, and we ended up putting about 40 or 50 patients on the battle trial. Now, it wasn't as many as the 300 at MD Anderson, but we started doing a tissue-based approach, and the team started to work together. And that's how we were doing that. And that was actually funded by an R01 that I brought with me from Anderson. But moving to what I want to tell you about in my first story is how can we do better in lung cancer? We're not going to do better by using these targeted therapies just in advanced disease. We have to find the disease earlier. And we're finding disease earlier because of screening and because of smoking prevention. And at the time that someone comes in for smoking prevention, that's a teachable moment. But we know that even in lung cancer, when you find it early, you know, and so often they find it in the emergency room these days, right? They're doing a cardiac scan or some other scan. Someone has a small nodule. The 5-year overall survival, even there, is only 60 to 74%. That's how metastatic lung cancer is. And if it's stage 2 with a few other nodes, 47 to 55%. And if it happens to be stage 3 with N2 lymph nodes or stage 3B, 38% 5-year survival. So even early disease, even with chemotherapy, is not as curable as we would like. So if someone has an EGFR mutation, which are about 10, 15% of the patients in the Western world, and as many as 40% in the East, Asia, China, wouldn't it be nice if we could, and we know that the percentage of mutations are about the same across the spectrum of stages, wouldn't it be nice if we could give the EGFR inhibitor earlier? So we sat down about 10 years ago now, a group of us, and I had a colleague, Masahara Suboi from Japan and Yilang Wu from China, working with AstraZeneca. We said, let's design this trial now. And they were very proactive, and they said, yeah, let's do it, because we knew an adjuvant trial would take a long time. So that's the ADAURA trial. And the idea was to take patients who had been completely resected for lung cancer, and you can see the eligibility here. And then we stratified them by their stage, 1B, 2, or 3A. They all had R0 resections, meaning all the tumor was removed with clean margins. We only took the 2 most canonical EGFR mutations, 19 and 21. And we did stratify by race. About 2/3 of these patients were Asian. You can imagine it. There were more of these mutations in Asia, so more patients went on there. And then the patients were randomized to, first, that they could get chemotherapy if it was deemed appropriate. Most of the stage 2 and 3 lung cancers get chemotherapy, platinum-based chemotherapy, and it's about a 5 to 6% improvement in survival. Not a lot, but it does improve survival. I would use it because it's something. But then we randomized to either osimertinib at 80 milligrams once a day or placebo. I'm often criticized, how could you do a placebo? Well, there were no data. There were plenty of trials before this that had tried other EGFR inhibitors and looked in this setting, and nothing worked. They were all too toxic. But we figured this drug was brain penetrant, it was EGFR mutation specific, it could be used and it would be safely administered. So we used osimertinib versus placebo, and we treated for 3 years. Now, the primary endpoint of this trial was disease-free survival, no disease recurring. Remember, they started with no disease, so we're seeing if anything recurs. And the trial was powered for a hazard ratio of 0.7, meaning a 30% improvement. So about, I guess it's almost 4 years ago now, in April, there was a safety review of the trial going on. No efficacy. But the chair of that safety committee, I don't know if anyone here has ever been on a safety committee, he said, something's wrong here. It looks like one of the groups is doing better than the other. And normally it's the control group is doing better, and they stopped the trial. But they actually looked at it and said, the treatment group is doing so much better, it's unethical to keep the trial going. So we actually got a call. It was in April. We looked at the data, and actually the hazard ratio, I'll show you in a moment, was so good that you'll see where things went after that. So this is what we saw. So this was, depending on your religion, it was Good Friday and Passover. I'll go with Passover. But you can see here it was in that year, the stage 1B and 3A patients. Here are patients who got the osimertinib in the adjuvant setting, and here is the control. And the hazard ratio was 0.2, or an 80% improvement. So that was phenomenal, better than expected. Of course, you would expect that this would work, but with this sort of separation and this sort of result, and it actually made a plenary talk at ASCO that year. And then we've updated it just earlier this year. This is actually the review at the time when it would have normally been analyzed, and it's still 0.27, or 73% improvement. So using a drug early keeps the disease from recurring. Now, where do you think the disease is kept from recurring from? Well, first, I just will show you that all parameters benefited. sex, age, whether or not the patient was a prior smoker, Asian or non-Asian, all 3 stages. Both mutations, you always do better with exon 19 deletion. It's a deletion versus the point mutation, which can revert a bit easier. And you can see whether or not the patient got adjuvant chemotherapy. When you look at a forest plot like that, for those who aren't used to it, anything to the left of 1 is good. And then if you look, what happened is in the patients who got osimertinib, you can see, actually, let's start here. Here, the patients who got placebo, 46% who recurred, you can see that many of those are distant recurrences. Whereas in the small number of patients in the early data who recurred on the osimertinib, on the treatment drug, only about half as many were distant. The drug is keeping patients from getting distant metastases. That's what causes patients to die, metastases to other organs, brain, liver, and bone. And actually, we looked at that, and this is pretty phenomenal. This is looking at the brain as the first site of recurrence, which is a major issue. If you ask a patient with lung cancer, he or she will tell you, I'm worried about my brain. We just had a EAB for our SPORE last Monday. That's exactly what our patient advocate told us. But you can see here's patients with adjuvant disease who got osimertinib. Here's the control group. Hazard ratio for recurrence in the brain, 0.24, meaning a 76% decrease in the first recurrence being in the brain. So it's keeping the tumor from the brain. We'll do this forever? Probably not, but it did it for a long period of time. We treated for 3 years. And here you can see now everyone was skeptical. You know, I never used to do the Twitter. Then I started doing the Twitter because people said you have to read the Twitter because people are being critical of your data. And now I don't know how to do Twitter because it's called X, and I haven't figured that out yet. But there were all these people that said, well, there's no survival benefit. Now, the drug got approved based on disease-free survival, but there hadn't been a survival benefit. And we had to wait for a number of years to have 20% of the patients unfortunately die because that was the endpoint that had been pre-specified to look at survival. And as a PI, you hate for that to happen, you know, because I'd rather there never be an endpoint because you don't want anyone to succumb to their disease. But I got a call last November that the trial was nearing the end, and it was you'll see it very interesting because Eric was here and the ASCO president. I'm thinking, well, this could be an ASCO presentation. So we're waiting for the data to mature over the winter, and then about March saw this curve, and this is the survival curve. And again, it was a very big DFS benefit, but in survival, the hazard ratio is 0.49. So here's the patients who got osimertinib, and here's the control. And you can see at 5 years, 88% versus 78%, so 10% improvement in survival. The hazard ratio, 0.49, so a 51% improvement in survival. And remember, the drug stopped here at 3 years. We only treated for 3 years. So now we have to continue to watch these patients. We have liquid biopsy samples. Hopefully next year I'll give another grand rounds. I have those samples. I'm analyzing them now, but we're not ready to talk about them, unfortunately, yet. And then it was pretty cool. So who knew that Eric was going to be the director here? It's just like it's almost like an amazing coincidence. He's the ASCO president, and there I am presenting at the plenary beside him and Kimi Ying. It was really pretty cool. And you really can't make this stuff up. It just sort of happened, right, Eric? Who would have known? So it was really, that was phenomenal. I was pretty nervous here. The best thing about the plenary is the green room. The drinks and the food in there, phenomenal. See, that's a secret of the ASCO. Okay. Now you see the overall survival, both if patients got adjuvant chemotherapy or without adjuvant chemotherapy. So you give it if, sometimes patients don't want it, and there's a big push now to avoid the chemotherapy. We're looking at that. But right now, we suggest that patients get chemotherapy if they can. And then, the big critique of this trial, and for those that read the New England Journal, there's a letter, I responded to a letter today from an investigator in Italy who said, well, not all your patients got osimertinib, so it's not really a fair trial. And they're right, not everyone could get osimertinib. But look, in the osimertinib group and in the placebo group, about 80 to 90% got an EGFR inhibitor in the second-line setting. Yet only 43% got osimertinib, but the drug wasn't even approved in the frontline setting when we started the trial. So, while it's not perfect, it's not a perfect, would patients have done better if they had gotten osimertinib early? Probably. But what we said in this reply is the difference is so great. I think use your best drugs earlier, and I think these data hold water. And then, it's not without toxicity. Be careful as physicians, as nurses, as caregivers. It's easy for you to say there's no problem. When you're giving a drug versus a placebo, there's always going to be added toxicity. And this drug does cause some rash, and it does cause some diarrhea, and it is debilitating for patients in about 4 to 5% of the cases. We have to be sensitive to that. Some patients need breaks, some need dose reductions. But for the most part, if you look at discontinuations and serious AE, there were 14% on placebo versus 20% on the drug, which is pretty low. But again, there is toxicity, and this is where quality of life and the survivorship clinic and others, we need to look at this and help patients. So what's in the future? We're continuing to follow the overall survival, because what's going to happen in 5 years and 10 years? We're doing a bunch of translational analysis. We're going to have Pasiani here for the Calabrese lecture this year. And he's going to tell us about persistent cells, which he studies, and Katie studies these as well. There are still cells that remain resistant to EGFR inhibitors. We actually have blood from about a third of the patients. It's very hard to get samples out of China, but from the Western world and from Japan, we do have blood samples and tissue samples. So we're looking at that. We're also looking at, there are trials looking at neoadjuvant osimertinib now. That's all the rage right now. We're looking at earlier disease. Adura 2 is looking at, this was stage 1B disease, so more than 3 centimeters. Everyone always calls me, what about the smaller tumors? I think it'll probably work there too, but we need to do the trial. And we're actually doing a trial where we're giving the drug for 5 more years, because there is some sense when you stop the drug that the brain metastases started to increase. So there might be some patients who are cured, in my opinion, but some who are just having cytostatic stability of disease, and that's something we have to figure out. So I'll just end this portion of the talk with this slide. So another mentor of mine, I don't know if anyone knew Josh Fidler, but I actually, when I was at MD Anderson, I had a small lab with him. And Josh used to always say metastases are what kill patients. And he talked about the metastasis cascade. So I think what we've really shown here is we've taken our best surgery and chemotherapy, and we've added targeted therapy to keep patients from progressing in the brain, liver, and bone. And I think this is a paradigm now we're going to see more of. The drug was approved, as I said, in 2020. There are a whole host of other mutations, as I mentioned. There's a trial called Alina that will be in the news in 2 weeks from today. You'll hear about Alina. This is alectinib. It's the Roche drug for ALK. And we have a press release that trial is positive for disease-free survival. And I bet they're not going to say, wait for overall survival. I think based on the Adura results, and actually Ann and I are going to the American Medical Association next week for a clinical trials meeting. And I think at that meeting, we're going to discuss this trial, because as a paradigm, what should the right endpoint be, in patients in the adjuvant setting? But I think we've shown that disease-free survival works. Okay, and here's a little plug for Katie. I don't have time to talk about this, but Katie and Sarah and Mark, what an amazing team. Mark's a little younger there. So here's the group. I'm a little older. So here's the group that's been meeting, and Mark's now the chief of pharmacology, and super duper team obtaining samples. You can see we have Anna and Heather and the entire team of getting samples from the clinic. We're banking the samples. We're looking at these samples. That's how science is going to be made, and understanding resistance. And then we also have project 3 of the SPORE, looking at brain metastases. I'm just putting a little plug in for that project. No time to talk about it today. And then this is important. We have an alliance with AstraZeneca. This has been critical for the SPORE, because by developing industry alliances, and this is one of the things I've been working on with the Dean's office in the last year and a half, and I'm really enjoying it, working very closely with Mena Wang, who's pictured down here, and here's Kathy Lynch from Yale Ventures. There's Pat. We started this together about 5-7 years ago. Here we are in Cambridge, 2017 and 2022. We all look the same. And you can see that this is just an amazing collaboration, because that's how we're really making difference. And I got to move on, but this is the timeline of that alliance. And here's the most recent visit. Actually, Dean Brown was with us. We're getting funds, but we're getting drugs and compounds, test compounds. Marcus, I see in the front row, I know he's very excited about this. It really is the way we're bringing this in, and we're expanding this now to head and neck cancers. We're heading to breast cancer and other cancers in the future. So this is going to be something that's with AstraZeneca and other companies that will, I think, be very important. So just in the last 20 minutes, a little bit about immunotherapy. That's also an amazing new paradigm in lung cancer, targeting immunotherapy. And of course, the checkpoint inhibitors. The first trials were done here at Yale. I don't know if everyone realizes that. And of course, we have Li-Ping Chen here. There's a very nice article about him in Fierce Biotech yesterday, talking about his contribution to the development and discovery of PD-L1. So this is probably the first responder in lung cancer. I don't know if Scott's probably in clinic now, because that's why he sees so many patients and helps so many people. So this is a patient, Maureen, who came to Yale, squamous lung cancer, wasn't a candidate for any of those targeted therapies, 3 times refractory lung cancer. And June 2010, she went on to the trial of MDX-1106 that Mario was running with Scott and Harriet. And you can see these large tumors in her lung and her liver. Within months, they responded. The trial was for 2 years of what we now know as nivolumab. Here she is at year 8, but her x-rays look this way now. She comes back. We've seen her. I'm sure Tara's seen her at some of the survivor events. This is the promise of a phase 1 trial of new drug development. Problem is, this is only 15%. But this is why everyone wants to work in this field. We see a light at the end of the tunnel. It's just a very long tunnel, but we know that 15% of patients are going to benefit. And then Scott, and he ran this trial, 003, and basically this is an actuarial survival curve because it's now with more than 5 years of follow-up. He published this in JCO in 2018. At 5 years in the refractory setting on nivolumab, 16% of patients are alive. And when I use this slide to teach in my clinical trials course, I talk about the tail of the curve because this is a non-proportional hazard. So you have 2 slopes, one here, one here. We know that there's a tail. The problem is, how do we get more people off the tail? These patients have primary resistance. There are other things going on. Maybe it's another checkpoint. Maybe it's a regulatory T cell. This is why we shouldn't just study the next PD-1 inhibitor or the next PD-L1 inhibitor. We need to think about what's going on in the microenvironment, and I'll show you how we're doing that. So just quickly, Keynote-1, Paul Ada ran this trial here at Yale a decade ago. It was melanoma, lung cancer, small cell lung cancer. This was with Keytruda, with pembrolizumab. That led to a trial that I led called Keynote-10, which established PD-L1 as a biomarker. If you have high levels of PD-L1, you do better than if you have lower levels. That led to using the pembrolizumab in the frontline setting, and then that led to adjuvant therapy. Sarah Goldberg and Harriet, working with Veronica Cheng, they did the first study, the very first study. And this is when, where's Ian? We could get the study, we got this open in 3 months, and we're getting back to that. They did a study where investigator-initiated study where they took pembrolizumab because we were already working with Merck, and they did it in, and we're still getting data from this, and we took patients with small brain mets. They had to be less than 2 centimeters. And we treated those patients with the drug without any radiation. If someone's going to live for 2-3 years, the 1-year survival with pembrolizumab in a high PD-L1 patient is 35%. So if you're going to be alive, actually the 5-year survival is 35%, excuse me. So if you're going to be alive at 5 years, you'd rather be alive without any cognitive impairment from radiation. So this was really established in this trial that was both a collaboration between melanoma and the lung cancer group. And you can see here's extracerebral response and brain response, and you can see they're about equal. And Harriet won't tell you this, but I'll tell you this, and it was in the New York Times, so I'm not breaching any confidentiality. But when a 99-year-old ex-president had melanoma in the brain about 8 years ago, they called us at Yale, and Wally Curran asked, "What are you doing with pembrolizumab in that setting?" And you can put the pieces together yourself. So what about precision medicine? How can that help? Well, David Rim, I was asked to be the discussant at ASCO about 6 years ago for the early studies on nivolumab. So I went to my good friend David, who, by the way, used to work on breast cancer, and he moved over to lung cancer, and now Eric's getting him back, and I'm a little worried about that. But it's okay. He works on the head and neck sport too. The pathologists are your pathologists, your statisticians, critical core members for any of these grants. You've got to have a good course. And that we always get exceptional, thanks to David and Kurt, and now Sonia's working with them. So you can see, I said, David, why is this PD-L1 marker so bad? And Li Ping was with us, and Li Ping said, of course it's not bad. I discovered it. It's actually very good, but you just don't measure it properly. And then David made this slide for me that everyone's now used, and I made sure the credit was there, David, so everyone uses this. And David has done very well at meetings and being involved in the panels. Here's one piece of lung cancer, one tissue piece, and 2 different areas. One area is stone cold negative for PD-L1 for 2 different antibodies, and one area is positive with 2 different results, slightly different. And it matters where you measure it. The green is cytokeratin, so that's tumor. The blue, the DAPI, is the nuclei, and you can see the red is PD-L1. It could be either in the tumor or the stroma. So it's the variability of measurement and the sensitivity of the assay. But you got to have PD-L1 for PD-1 and PD-L1 blockers to work. And we're so fortunate. So Katie deserved 2 awards last week because she and Scott set up this amazing repeat biopsy program. And that's why we got to make sure the freezers are backed up in our office. And we also have to make sure we have more liquid nitrogen because these samples are so valuable. Because for the last decade, the lung group has been collecting samples when someone comes in and they have recurrent disease, and they've putting a little plug in for so when someone comes in and they have recurrent disease, we actually get consent to get their old biopsy. And then when we get the new biopsy, the biopsy is done with the help of the team. And there's Anna Heather works with her sometimes, Gupang. I don't know if he's here, maybe he's online. The team gets a fresh biopsy and we get fresh tissue and we get paraffin. We make transgenic, we make PDX mice. This is and Zenta or a pathologist is usually there to make sure we get good tissue. This is the key, having samples from refractory patients. We started this with TKIs, but then we did this with IO agents. We wouldn't have the spore 10 years ago if we didn't have this data set. And we've used this both with our own samples and with industry. This was a very nice trial that Scott and I and others did with the drug known as MDX-1107. Now it's known as atezolizumab. So this was a phase 1 trial which we led here at Yale, and actually was published in Nature almost a decade ago. But in this trial, we had patients with lung cancer who responded to a PD-L1 inhibitor. But because we could get those fresh biopsies, we had pre and post biopsies. So here's a pre-biopsy on this responding patient, and you can see CD8 positive T cells, and then post, you can see a lot more. This is what you call the adaptive immune response. This is the blocking the PD-1, PD-L1, upregulation of interferon, T cells coming to the tumor. And then using an RNA chip, and why did we get this trial? Ira Melman. Good old Ira Melman had moved to Genentech, and I went out and had dinner with him. I had remembered Ira from cell biology. That was when I was at Rockefeller, Don, but still I knew Ira. And Ira helped us to get this trial. And with Ira's group, did this work for us, the RNA chip. And you can see pre and post, green is pre, yellow is post. You can see this is an example of what's happening when the immune response is active. So we understand what the active immune response is. Problem is, how do we get this to go on in every patient? 20% of patients responded in that trial, but the other 80% did not. And those patients that did not, we described in this paper, the immune desert. CD8 before and after, the tumor just laughs at the PD-L1 inhibitor. Nothing happens. Or you can have a non-functional immune response where you have some CD8 cells and maybe a few more post, but if you look at that immune chip, completely flat. And then this is actually something we're seeing more and more of, and I don't have time to talk about it today, but our next trial on the spore is going to target this, that the cells that get inhibited, that can't get to the tumor because you get this line of interference, and we call this the immune excluded cells. So more to come on this. I'm going to skip this for the sake of time. Always have to do a little editing. So I will just say that now all these agents are moving up front. We're now in the process of taking immune therapies are being used in the neoadjuvant setting. And it's actually a very fertile time because when we sit at the tumor board, we have to decide, are we going to do surgery and adjuvant therapy like I showed you for a TKI inhibitor, or we're going to use the neoadjuvant therapy first. And we're seeing about a 15% path CR rate and a 30 to 40% minor CR rate, major PR rate, when we use these agents up front. So that's going to be the next stage, neoadjuvant trials. And I just want to make a plug for tumor boards. This is sort of what our tumor boards look like lately. So I would just like to, as long as I have the podium today, encourage people to go to tumor board. Let's start having our tumor boards hybrid. We can't have them all in person because we're 15 sites, but the tumor board discussions are going to be really critical. These are drugs that were approved from Yale-led studies. Very proud of that. All these drugs had some of their first studies here at Yale in the lung program, and we have many more to come. And we're seeing that in all of our programs, and that's our experimental therapeutics, our DT. We can do the science on these studies. But the reason I skipped is I'm much more interested to tell you about the future. So we now have to target immunotherapy. What I showed you at the beginning of my talk was how we used targeted therapy. We understood the target, brought it earlier to have the greatest advantage. And I told you about the biobank we have. Well, let me show you how it has paid off. So here we had patients who had immune therapy and they responded, and then they had more immune therapy and they became resistant. So thanks to that protocol that we've had running for, I guess, what Katie, 12 years or more, right? And we now have tumor tissue, germline DNA, pre-treatment and at resistance. And working with Rick Lifton a number of years back before he left and his lab, we sequenced all of those tumors. And very interestingly, you can see here the 14 tumors, and you can see the first response shown here in the green and the resistance shown in the yellow triangle. So we had pre and post samples on patients who responded and then became resistant to immune therapy. And you can see it was from a hodgepodge of different trials, some with anti-PD-L1, some with anti-PD-1. The drugs are different, but quite frankly, for this type of analysis, I don't think it makes much of a difference. Well, two stories emerged from this. They've both been published several years back. One that Katie and Scott led, where we actually had one patient. This patient was on tremelimumab and durvalumab had a tumor that responded, and then it became resistant. And actually, by looking at the biopsies pre and post, we didn't see much different in PD-L1. But what we did see is this is loss of beta-2 microglobulin. So if you look at copy number, there was already loss at pre-immunotherapy. The patient had already lost one copy of beta-2 microglobulin. And then when the patient became resistant, they lost both copies of beta-2 microglobulin. Now, beta-2 microglobulin, of course, is an essential component of MHC1. So these tumors lost the ability to present neoantigen to T cells. So we are actually seeing that about 5 to 10% of the time in lung cancer. So these patients are going to need more. This immune approach won't work. We need to use other ways. Maybe the innate immune system is going to be the way we target these tumors, NK cells or something like that. And then what Kurt and David did is, this is quantitative immunofluorescence. We took a whole bunch of samples of responders, non-responders. These are samples that Scott had collected over the years. And we looked at those samples and we stained for CD3 and double labeling. And we looked at CD3. So we looked for tumors that were low CD3, so low T cells. We looked at tumors that were low CD3, high CD3, and low granzyme and Ki67. And the idea there were these are tumors that were not activated in their T cells. And then we looked at some tumors that were high CD3 and high granzyme and Ki67. And the granzyme and Ki67 are the white and the green. And I would have predicted that this is the group, group C here, that would have done the best. But interestingly, the group that did best was, you can see here's the type 2 group shown here, high CD3 and low granzyme and low Ki67. So why is the group that has many T cells but has the non-activated T cells doing better? And that was something we really couldn't explain until recently, when Liping Chen and Kurt and others, Magal Sanamemed, who was in Liping's lab, did a study and actually using CyTEP analysis showed that many of those T cells that are in the tumor are burned out. They're not active. And it probably explains why chemotherapy works with immunotherapy, because chemotherapy kills the T cells that are in the tumor microenvironment, making room for more active and newer T cells to come in. This is a work in progress, and we need fresh tumor samples to study this more. But the idea is that it's the quality of the T cells in the tumor that matters, not just whether the T cells are there or not. In the last few minutes, I just want to tell you about one more story, and that's how we look at resistance. So what we're thinking here in our group is when we looked at 250 cases of lung cancer, you can see that about 17% of these tumors were high PD-L1 and high TIL. So they have a lot of PD-L1 and a lot of T cells in the tumor. These are probably the tumors that responded quite well to immunotherapy. But here's another 26% of tumors that have high TIL, there's a lot of blue, but no PD-L1. So probably suggests there's another checkpoint in play. And then very interestingly, 45 or 20, 70, 57% of lung cancers are cold. So it's really these type 1 tumors I've already talked to you about. These are the type 2, I'm sorry. These are the tumors that probably respond, have a durable responder, Maureen. They either acquire resistance like I just showed you, or they're probably resistant for mechanisms we don't yet understand. But it's the other tumor types that we've been targeting in the spore. And type 3 are the tumors that must have some other checkpoint. So Liping, and I became involved with this because I did a sabbatical in his lab in 2015. And they were working on this project. I said, can we bring this project into the spore? And he said, sure. He was developing it with a company called NextCure. And this is a drug known as Siglec-15. And I'm running low on time, but basically this is a homolog to PD-L1. And in tumors that are interferon high, that activates PD-L1, but it actually downregulates Siglec-15. So it makes sense that this marker, this protein might be more important in tumors that are PD-L1 negative. And actually, that's been shown. So here's Siglec-15 and here's PD-L1. And you can see in tumors that have Siglec-15, it's a suppressor of T cells. So the idea was, could this be an alternate target we can use in these tumors that are low PD-L1? And the answer is yes. We were involved in the phase 1 trial. Pat LaRusso was the PI on that. We did that with a company. There's a company-sponsored trial. Oftentimes, you have to do the first trial with a company, and then your next trial can be your own IND. So the first trial was a company-sponsored trial. And you can see here's patients, 2 patients with lung cancer who had response, one with a complete response, one with a partial response. Here's that response in lung cancer. It wasn't here at Yale, but this was a patient who had already had immunotherapy and failed. And you can see they're responding to the Siglec-15. But the phase 1 team, Katie Kirk was here. We got a nice picture. She did the picture, not me. She had her own photographer with her. And then this is what I want to show you. Scott Gettinger has these data. I presented on his behalf. I couldn't make the meeting, but this is Scott's work. Scott has led a trial of NC318, which is the antibody against cyclic 15. And this is totally investigator initiated. Yale holds the IND. We've put almost 40 patients on this trial. We have 2 arms of the drug alone, different schedules. Then we combine the drug with pembrolizumab, the PD-1 inhibitor. We also have an arm of IO-naive patients. We're just starting. So we've been studying this here at Yale. We've been getting biopsies pre and post. And again, I don't have a lot of time left, but I'll just cut to the chase. The biomarker that David's been developing has been helpful, but to date, as always happens, we don't get biomarker on the patients that have the best response. We actually just had another response yesterday, so stay tuned. But what we have done is we've looked at patients, and we've looked at a number of patients have benefited. Some of them that are getting pembrolizumab plus cyclic 15, and some of them cyclic 15 alone, and you can see we're seeing PRs. I'll tell you, as someone who works in this field of lung cancer, to see an immunorefractory patient respond, you can count on one hand how often that happens with some of these new agents. So we're very excited about this. We're trying to understand the molecular mechanisms, but we've had 4 responders now to the combo and 1 to a single agent. And actually, pictures are worth 1,000 words. So here's that patient who had got the single agent, a liver lesion that's responded. And here are 3 examples of patients who are responded to the combo. So we are seeing activity here, and we're in the process of working with NextCure and with other groups to decide what our next trial will be. So I'm going to skip this. I'm running late. I was very ambitious. I haven't given a live talk in many years. Okay, but what I do want to tell you about is just get to the end. So what I've tried to show you today is we're making progress in this disease. It's really phenomenal progress. Doesn't always seem like that if you're on the inside, but if you look back at it from a 20, 30-year perspective, we now have patients with lung cancer. Ironically, the patients who are smokers who have many more mutations probably have the chance of cure with the immunotherapy. And as we move that immunotherapy earlier, maybe even more so. But the targeted therapy produces amazing benefit and quality of life. And if we use it earlier, I believe we could probably cure some patients there as well. The theme, I think, of Yale as a whole, and certainly of the lung group, is that we used to call these darts. I haven't made change the slide, but our clinical trials team uses the institutional science and our industry collaborations to develop trials that lead to advances, grants, and we're feeding on that cycle. And we're building a team that's focusing on lung cancer advances. We have many other targets. We're working with Aaron Ring's AL18 BP and the melanoma group and the lung group as well. CD93 is a target for vascular permeability. We're starting to work with here at Yale with Li Ping and other targets. And I didn't know Don was going to be here, but we're certainly interested in the FLIP as well. We're doing trials. This is an example of a biomarker adaptive trial we did with Merck. But I'd rather tell you about the trial that we're developing in the last minute called the iBulldog trial. And Mayna's here. So Mayna's been coordinating with us, doing a great job. How are we going to do another battle trial here at Yale? What I would suggest is we have to pull together and do a trial where we now take advantage of the pathology that I've shown you today, of the science here at Yale, and of our ability to do clinical trials and lead that next generation of studies. And we are now looking for new ideas. Here's our current idea that we've been shopping around, and we've had meetings with 3 different pharma groups in the last month, and they're all interested. So we'll have to see who works with us. We're really excited about this. And we're going to do real-time tumor blood, real-time immune profiling. We can do that here. We can do it in a CLIA appropriate way. And then we're going to initially equally randomize patients to treatments. But then once we learn about how these biomarkers portend response, we're going to do a biomarker enrichment adaptive randomization. And Steve Ma is very excited to do that with us. Here's the team that's working on that, just the core team, but we'll be getting everyone involved very soon. So as I conclude, can we cure metastatic lung cancer? Yes. I couldn't have said that 10 years ago, but only in some cases. We have 12-plus-year survivors from our very first trials. Treatment was well tolerated and retreatment was possible. I didn't show you that, but sometimes you can retreat. But we don't even know what the markers are for that. But the problem is we don't have any way of knowing this in advance. We've got to do more biomarker work. So do we need to personalize immunotherapy? Absolutely. We spent 20 years personalizing targeted therapy. You'll hear about that next June 10th, but we're still not there yet. We need biomarkers and better combos. We need innovative trial designs, but the future for this is now. So last slides, we need to personalize immunotherapy, identify biomarkers and improve combination therapy, identify new targets and rational combinations, establish novel endpoints, innovative trial designs. We can do that here, address mechanisms of resistance, and bring disease early is sort of reads like the CCSG. We can do it, but my charge on this first grand rounds of the Friday to the fellows, to the scientists here, the translational scientists, everyone, we're a continuum from the clinic and the lab working together to help the patient. We need to develop drugs in real time, and it's only going to be with science. Ben Lewis here, he gave an amazing talk the other day on a trial that we're doing with ipilimumab, nivolumab, biomarkers. That's going to be the future, but then to translate those into new studies. So I'll just end with a picture. So this is Ben's talk the other day. We had 50 people at a translational lung meeting. Katie and Sarah have been organizing this. This is how we're going to make progress. We have to meet on a regular basis, go over our science, do as many IITs as we can. This trial actually was a trial of ipilimumab, nivolumab, that we went to meet with Bristol Myers at the Yale Club about 6 years ago, several of us. And we're not running it under our own IND, but we're getting the samples. We just got to get the samples here and get the science here so we can make the next step. So with that, I'll just end by saying, save the date. Katie and I and the whole committee are going to hold the Interspore meeting here next June, and we're going to be celebrating 20 years of EGFR mutations. The guest list is everyone's saying yes. The hotels will be full. So with that, I'll thank you very much. It's the hour, but I'm happy to take 1 or 2 questions. I'm supposed to look online. A lot of people online. Oh, here's a question. Yeah, so immunotherapy in the adjuvant setting does seem to have some benefit. The results are a bit mixed. With atezolizumab in a trial known as Keynote-10 in the adjuvant setting, in patients that were PD-L1 more than 1%, the hazard ratio is about 0.6, 0.7. So there is a benefit. But if you look at those patients who were PD-L1 negative in their initial sample, there was no benefit at all. Pembrolizumab, interestingly, in a very similar trial, didn't see any biomarker prevalence, but they did see a benefit as well. My sense is that neoadjuvant is probably better because and it comes from melanoma. I see Marcus shaking his head. Yes, in melanoma and in lung cancer, you have the tumor and you have the lymph nodes that are involved as well. So if you use your immunotherapy in the neoadjuvant setting, you've got the tumor in situ in its microenvironment with its lymph nodes. So you really get the entire T cell microenvironment, I think, affected. So it's better. The problem is we're only going to be able to do neoadjuvant on a selected group of patients. What we're seeing now is, I'm sorry I didn't have time to show those data, but it works, but you have to pick carefully because you're not going to really take someone who's not a candidate for surgery and bring them towards surgery. So we have to be somewhat selective, but at tumor board, we'll look at a case and we'll say, this patient looks like they're surgically resectable. They can take the 3 months to get the neoadjuvant therapy, and we're treating those patients in that way. Some of them might not be in that situation, and chemoradiation, David, is with immunotherapy is also very beneficial. So we have multiple options. I'll leave you with this word: everyone should get immunotherapy in some way if they can. The patients that don't get immunotherapy would be ones who have autoimmunity or some reason that they're intolerant, or certainly those with molecular drivers, because in those cases, we know immunotherapy doesn't seem to work as well. But I'd say if there's any hint of metastatic disease, I try to find ways that I can give immunotherapy to a patient. Yes?
Any thoughts on, can we target that, or why doesn't EGFR inhibition work for those that bigger pie?
Yeah, we've tried that. In fact, that was the markers we worked on in MD Anderson, and actually we worked with Jose Bazaga on that many years ago. We thought it would be EGFR expression. And that is helpful, if you're using an antibody. That could be, if you're using cetuximab in certain tumors, but it really isn't. It's not the absolute level of EGFR, but it's the quality. It's whether it's being driven by those mutations, and the TKIs, or if you've got that addicted tumor, then the TKIs will have that amazing effect. But the expression can be helpful maybe for ADCs right now. Now there's a whole new. Now that we're sort of at a standstill with new immunotherapy resistant drugs and with new targeted drugs for EGFR resistance, we're using the address now with payloads. So that might be an area. Don?
Since early detection is such a key piece of the puzzle, what are your thoughts on possible innovation?
Well, certainly, there's the easy one, which is screening, which now with helical CTs and low-dose CTs, it does pick lung cancers up earlier, and it's been shown to improve survival. In the US, only about 7% of patients eligible for screening get screened. The criteria were a bit strict. They've been reduced a bit, but it has to have been someone who's had a smoking history. So of course, it doesn't take into account any of these patients who are the never smokers or the light smokers, which are the ones that have these different mutations. Certainly, looking in the DNA and ctDNA, I think that's going to be the way to go. We're already using that for minimal residual disease, both to determine whether or not patients need more therapy. And now, of course, we can look at the quality of what we're finding, what are the new mutations. Those techniques are getting more and more sensitive. I'll tell you, in the ADURA trial, we only picked up, post-resection, a sample 10–20% of the time. So even though many more of them probably did have residual disease, but it's getting more and more sensitive. Now, you asked about, screening someone with a history or a family history, or will we start looking for tumor DNA? I think we need a lot more work to do that. But, the techniques are getting so much more sensitive. Certainly, if you know that someone has a tumor, or if they have melanoma, you know what the antigens are. So you know what panel to look for. In lung cancer, which has so many different, types of mutations, there is what Charlie Swanton is doing now, and I would put my money on his approach. The bespoke models where you actually can sequence a tumor, get a panel of mutations, and that makes your sensitivity much better. Absolutely, and that's something we've talked about, and maybe I know David and I have talked about it, and both Davids. We don't really have a liquid approach here, so we need to think about how we're going to. Maybe that's the way to jump forward. You need AI, you need pre-competitive collaboration, you need big data sets. There's a meeting in 2 weeks at the National Academy of Medicine on public-private partnerships and data sharing. We're going to have the editors of some of the big journals there. We're going to have people from UK, from Wellcome Trust, from the NCI. That's what we need to take these big approaches, large sample sets. I'd love to talk to you more about that, get your ideas. I think we better stop because it's late. Sorry to go a little over, but thank you all for coming. It's exhilarating to see people talk to a live audience. So thank you.